Thank you for joining us. I'm Guy Carrick with St. Elizabeth Healthcare in Edgewood, Kentucky. Today we're going to talk about ACL injury. Joining us to my immediate right is Dr. Adam Metzler.
You got it.
Got it, with Sensi Orthopedics and Sports Medicine. He performs his surgeries at St. Elizabeth. To my left is Chris Coleman, a physical therapist at St. Elizabeth. And to my far right is Molly Schweitzer, who has a personal experience with ACL injuries, who we will hear from later. But right now, before we actually get to the segment, I want to remind viewers, if you have any questions, feel free to post those on the comments section throughout the broadcast, and we will answer those. So let's introduce Dr. Metzler, and if you could just tell us, introduce yourself and what you do as an orthopedic surgeon.
My name is Dr. Metzler, originally from Fairfield, Ohio, and married with 3 children. Live in Fort Wright, and our kids go to St. Agnes, so a big part of my life is my family and wife, so I want to make sure I give kudos to them. I'm a sports medicine orthopedic specialist specializing in shoulder and knee minimally invasive arthroscopic surgery. I have a fond interest in specialization in anterior cruciate ligament, also known as ACL surgery. I do about 100 ACL surgeries a year. A lot of what we do as orthopedists is we try to repair tissue that's been torn or injured, and or we repair fractures, which are broken bones, and try to put them back together. So a big component of my practice is what I call sports medicine surgery, or arthroscopic surgery, where we're trying to take tissue that's been torn and put that back to its home, if you will, and or taking a fracture or broken bone and trying to straighten it back out, maybe put a plate or some screws on it.
Okay, well, thank you for taking the time to join us today. So let's get started. What is an ACL injury and what causes them?
So the ACL is one of the central ligaments inside of the knee, and it's also known as the anterior cruciate ligament. It lives just in front of the PCL ligament, and they crisscross each other. The term cruciate is actually Latin for cross, and so it sits right in the front of the PCL ligament, and its main function is to prevent the tibia bone from translating forward on the femur bone and preventing rotation. So those two structures, or two components, are really important for what the ACL does, and it's very important for stability, giving patients and workers and athletes the ability to cut and pivot and plant and feel comfortable to be able to rotate and take a step without their knee shifting or translating.
Okay, and what are some of the things or exercises that someone can do to help strengthen their ACL?
Well, you can't individually strengthen the ACL. What you can do is strengthen the muscles around the joint. Just like if someone has an ankle sprain, we're going to encourage them to strengthen the muscles around their ankle joint to help to prevent further injury. We think of the same concept for an ACL injury, whether it's pre-injury, pre-surgery, or post-surgery, the same concepts are going to apply. So we're going to try to strengthen core, hip, and quadriceps muscles or thigh muscles to try to provide stability to the knee and to try to prevent injury. So when patients ask, well, what can I do to prevent an injury, the most important thing we can do is we can work on what we call neuromuscular training, which basically comes down to having good core, hip, quad strengthening, doing plyometric exercises, particularly for females with good landing mechanics, so they're landing in a normal alignment. So those are some things that patients can do to work out, making sure they're maintaining good form in the gym, when they're doing squats with good form. All those things help to strengthen the muscles around the joint, which helps to prevent injury.
Okay. And when you see an injury, how do you treat the injury?
Well, the first thing is obviously your physical exam and your history. So you want to take a good history. And interestingly, with an ACL injury, about 75% of the time, they're associated with a pop and their knee swells. And so just a history alone, if you take a good history, you're going to get to the bottom of an injury, particularly an ACL injury, pretty quickly. And then a good physical exam, you're going to narrow it down even farther. And a lot of times we're going to get an MRI, which is a magnetic resonance imaging. And that allows us to look inside the knee. And again, about 75% of the time you have an ACL injury, there's other associated injuries such as meniscal tears, cartilage injuries. And so we're going to almost always get an MRI to make sure we're not missing another component of the injury that happens and or occurs with an ACL injury.
Okay, and is surgery always necessary?
It's a wonderful question. In general, for someone who's active, it is recommended to have an ACL reconstruction. For patients who are not as active, maybe sedentary, or they don't do high-level sports or even moderate-level sports, the answer generally is that most patients will need an ACL to feel comfortable, to be able to do basic activities. I've done ACLs on 60-year-old farmers who had unstable knee, from their ACL injury and weren't comfortable walking around in the mud on their farm or climbing on their tractor, to weekend warriors to high-level athletes. Some patients choose not to, who don't do any side-to-side cutting or pivoting. Interestingly, you're a runner, and I'm going to answer this question before you get to it, but if you're just running straight line, your ACL really doesn't come into play. It's when you run straight line and you have to make a cut is when you need your ACL. So most patients want their ACL reconstructed. They don't like that feeling of instability when they shift their weight from side to side. And so I'd say the majority of the time we are reconstructing patients' ACLs.
Okay, and you've already answered part of this next question, but I want to ask it, what are the benefits with the surgery?
So the main benefit of the surgery is to provide stability. And that's the thing I tell patients, is we want to give you a stable knee. We want to give you a stable knee so you can be active, you can get back to work, you can hopefully get back to sports, and have a stable knee to be able to cut, pivot, plant, and translate your body in space without your knee giving away. It gives you that sense of confidence. For a lot of workers, it's just the ability then for them to be a construction site, be on a beam, be on a concrete pier or something, and feel confident their knee's not going to give away. For our athletes, it's the ability to run down the court, pass the ball, plant, go, do a layup, and feel confident they can do that. If they don't have their ACL, it's very difficult to do that.
Okay. Now, someone comes to you and now they have to have surgery. Is there anything that they can do, exercises, maybe something before the surgery that could help with the recovery afterward?
Yeah, definitely. So this is where we come to play with what we call prehab or pre-rehabilitation. I think it's very important. It's actually been shown scientifically to improve outcomes for patients. And so what we want to do is make sure that they have minimal swelling, good motion, and we want to make sure that that's present before we take them to the operating room. So we want pretty much their knee to move and look like their good knee before we're taking them to the operating room. And so they should be doing icing, swelling control, compression. They should be working on just early quadricep strengthening, like straight leg raises and quadriceps contractures, and making sure they can get full extension and full flexion. And there's exercises that our therapists at St. Elizabeth will oftentimes help us out with.
Okay. I do want to remind viewers to feel free to submit questions. We do have one. And you've mentioned this, so what does good mechanics mean?
Good mechanics, so if we're talking about a squat, this is getting a little bit beyond ACL, but we're talking about when you do a squat, you arch your back, you drop your behind, you keep your knees behind your toes, and by doing a good squat, you're actually working three joints. And more than that even, but that's the hip, knee, and the ankle joint. And if you do a good squat with good form, then it doesn't overload the joints and put too much pressure on it. It also allows you to better strengthen the muscles around those joints.
Okay. Now I want to get back to the surgery, and you and I talked a little bit about this ahead of time. What actually happens during the surgery?
So when we talk about ACL surgery, the majority of the time we're talking about a reconstructive surgery, and that's where we're going to take a piece of tissue from your body, usually, and we're going to take that tissue and we're going to place it within inside your body. And we do that by drilling a hole in the femur bone, and we drill a hole in the tibia bone, and it allows us to insert a piece of tissue, either your hamstrings, a piece of your quadriceps tendon, or a piece of your patella tendon, oftentimes linked with either screws or buttons that hold this into place and allow it to be stable. And that's how we accomplish this surgery. It's through a relatively minimally invasive surgery, but for most of our active patients, we're going to have to use their tissue, and we call that autograft tissue. For patients who are a little bit older, we might use cadaver tissue, also known as allograft tissue. And after the age of 30, those results are about the same. But in younger patients, we try to stay away too much from allograft tissue just because there's a slight higher failure rate.
Okay. And how long is the incision, and approximately how long does a normal surgery take?
So surgery in general is going to take us between an hour and a half, really depending upon what other associated injuries the patient has. So if they have a cartilage injury, maybe a meniscal tear, we might see they may need to take a little bit longer if we need to repair that. From the incisional length standpoint, it does depend on which tissue type we use. If it's a patella tendon, it's typically going to be about 5 to 6 centimeters, the hamstring 3 to 4 centimeters, and then we use other small 1 centimeter stab incisions, little small incisions, to work using our camera. Something that used to be done with maybe a 14 to 16 centimeter incision on the front of the knee, we can now do through a relatively minimally invasive procedure. It's significantly smaller, and that allows for patients to rehab quicker, as we're not taking down some of the other larger structures like the medial retinaculum and have to protect those as they rehab.
Okay, and do you consider that a routine surgery, a routine procedure?
The ACL surgery is considered a routine procedure. There's probably 250,000 of these that are performed each year in the United States. It typically is recommended to be done by a fellowship-trained orthopedic surgeon who's doing these consistently. The outcomes typically show higher patient satisfaction, less re-tear rate. So most of us, like myself, who are fellowship-trained, are doing the majority of these ACL surgeries at large cities like Cincinnati, but it is considered a routine procedure.
Okay, and do most insurances cover the procedure?
Most insurances do cover this. It's considered a cost-effective procedure, and these are studies that are done that look at, is doing a surgery cost-effective for a patient? And really what they're looking at is, can patients return to work to produce for their family by having a stable knee? And another example of that is total hips and total knees are considered cost-effective surgery, so they improve patients' quality of life. And so ACL surgery is one of those surgeries that's been shown to be a cost-effective procedure. So most of the time, insurance companies are going to approve this surgery.
Okay. Let's take a break here. I want to remind viewers, if you have any questions, feel free to submit those. At this time, let's bring in Chris and talk to Chris about, if you can introduce just what you do as a physical therapist, and then we'll see how that relates to ACL injuries.
Sure. I'm Chris Coleman. I'm a physical therapist with St. Elizabeth Healthcare. I work in sports medicine, so I kind of have a specialization in higher level athletes, but we do see all patients from the general population. We do see a lot of ACL surgeries. We do see a lot of total knees, total joint surgeries. So that's primarily what I work in the outpatient
Okay.
clinic.
And from a rehab perspective, can you describe what that's like? And do they receive that at home, or do they get that in the outpatient setting?
So they do come to my clinic or our clinic usually 2 to 3 days a week at first. They are expected to do some home exercises also. There's kind of two different programs. The first visit we do focus on the home program, get them going on a good home program so that they can get started on doing some of the exercises that they're going to need to do every day. And then there's kind of a different set of exercises that they do when they come back into the clinic. And so we kind of progress them into the clinic. And then we also progress their home program as they get more strength and can advance to more exercises.
And is there anything a patient can do to kind of speed up the recovery?
Not for. Are you talking specifically for an ACL?
For an ACL.
Person? Yeah. There's things they can do that make the recovery go a lot smoother. Things like getting their range of motion back as soon as possible, especially extension. A lot of people tend to focus on bending their knee and getting their knee bent, but actually extension is actually the most important thing to get as soon as you possibly can. That helps to speed things along. Once you get extension, you can get a better quad contraction, and then getting a better quad contraction, then you can start to strengthen the quad a lot faster.
So you talk about being able to bend the knee. What are some of the exercises that you do with a patient with an ACL injury?
So there's three main types of exercise. One is passive range of motion, which is a range of motion that's performed by usually the therapist. So that's hands-on, stretching the knee into both extension and flexion. There's active assisted exercises, which the patient will use some type of maybe a towel or a strap or something to kind of help hold their knee bent. Things like the wall, sliding on the wall, things like that. And then there's active range of motion, which is the patient actively doing some exercises and doing some strengthening type exercises.
Okay. Approximately how long does it take, I don't know, using the word typical patient, but how long does it take a patient before they can return to walking?
They're as soon as possible. So they're walking. They're usually weight bearing as tolerated using crutches in a brace for probably the first 3 to 4 weeks. They'll be in the brace for, depending on the protocol, usually a couple months, but they'll be walking in the brace. As soon as we can restore normal gait mechanics, the better. So typically a patient can drop to maybe one crutch after 2 to 3 weeks. Then the goal is by 4 weeks they're not needing the crutch anymore. They're ambulating still in the brace.
And then along that same line, how long before someone can start pursuing their normal activities of daily living?
Activities of daily living return pretty quick. Kids that have the ACL that are in school, they might miss a couple of days of school. They'll go back to school. Someone that's working, if they have a sedentary job, they can go back to doing their desk work and after about probably a week. Obviously, people that are in higher level jobs, workers, factory workers, or whatever, that are going to be on their feet, they're going to be off for extended periods of time. But activities of daily living is you get to return back to pretty quick.
Okay, and you alluded to this a little bit earlier, but I want to ask it again. Could you just describe again what happens to the range of motion with an ACL tear?
So immediately post-op, obviously the motion is a lot less because of all the swelling and things in the joint. For the first probably 4 weeks, you're limited. We want to get that extension back week 1. If we can get full extension within the first 2 or 3 days, that's what we want to do. The bending, sometimes, depending on if there's other things that let's say there's a meniscus tear, you're usually limited to 90 degrees of bend for the first 3 or 4 weeks. So there's a little bit longer progression as far as getting it all the way bent. But eventually the range of motion goes back to full range of motion. We use the other leg as kind of the goal to get back to that same range of motion as the other leg.
Okay, and if someone's knee is feeling better, what would you tell him or her if they wanted to kind of get back into their activities a little bit sooner than that? What would be your piece of advice?
Well, if it's sports, we can't really do anything about. There's no really speeding along the return to sport as far as like the timeline that it takes. It's still going to, average is probably 9 to 12 months now for returning to sport. So no matter how good, because usually you start to feel really good after the first 6 or 8 weeks, you're feeling kind of back to a normal really as far as the knee. So getting someone to still be patient and say this feels good, it's moving good, but there's still a timeline that we have to follow as far as return to sport.
Yeah, that's a good point.
Yeah.
Well, let's stop here. And I want to remind viewers again, if you have any questions, feel free to submit. And I think before we bring in Molly, we do have a question from Brad. Maybe Dr. Metzler, this might be for you, but we hear we hear ACL, MCL, PCL, they're all used together. We're talking about ACL injuries, but can you describe each one of these and how they affect knee movement? I guess there's a part 2 with this too. I think you do have a model if you can physically
absolutely
show on the knee ligaments what we're talking about here.
Hopefully everyone can see this here, but this is a knee. This is actually your kneecap. This is your quadriceps tendon. This is your patella tendon. This is the MCL, and that is short for medial collateral ligament. Structures on the inside aspect of the body are known as medial, and outside aspect are known as lateral. So each knee has a medial, and each knee has a lateral structure. If we look inside the knee, we're going to see the anterior cruciate ligament. I don't know if the viewers can see that there, but this is the anterior cruciate ligament, again known as the anterior cruciate ligament ACL. Okay, and then the PCL ligament is going to be on the back here in the back side, and they do crisscross each other as we talked about. And anything anterior means front and posterior means back in the body. So their purpose is for the anterior cruciate ligament, again, is to prevent the tibia from sliding forward and rotating on the femur. Okay? And then the MCL, its purpose here is to prevent your knee from opening on the inside. And then the purpose of the lateral collateral ligament, or the LCL, its purpose is to prevent your knee from opening what we would call a varus stress, so the outside aspect doesn't open up or gap. Okay, and the deep within the knee also the shock absorber is called the meniscus. And I think the most important reason we actually do an ACL surgery is to provide stability, number one, but number two, we didn't talk about earlier, is to prevent these meniscal injuries from occurring. Because the more your knee is shifting side to side, when you don't have an ACL, the more likely you are to tear your meniscus. The meniscus are really important because if these guys tear, they actually can result in earlier arthritis. You can imagine if you don't have part of your O-ring present in your car, that component of the car will wear out earlier, and it's very similar to a knee. When your ACL tears and your knee is constantly rotating, if you don't have it fixed, then your meniscus can get torn, and then secondarily you can develop early arthritis. So hopefully that answers the question that was called in, and hopefully everyone can see the anatomy that we went over here today.
Yeah, thanks for the explanation. Well, at this time, let's bring in Molly. Molly, again, thank you so much for joining us. Could you just describe what happened that caused you to come in and have the surgery?
Yeah, so last year, it was actually the third varsity practice basketball, and we were just doing a normal drill, like nothing was different, and all of a sudden I turned funny and I heard a pop in my knee, and that, like, at first I had no clue it was the ACL or anything. I wasn't even thinking that. And then I tried to get up, and that's when I could feel like it wasn't stable at all. And that's when the athletic trainer came and evaluated me, and that's where I got sent to get MRIs and it evaluated.
And what made you choose Dr. Metzler and St. Elizabeth?
So actually, Dr. Metzler was recommended by a family friend of ours, and also from my athletic trainer at Boone County, Tom Burns. We call him Burnsy. And so he's the one. Those two people are the ones who sent us to St. Elizabeth to get surgery.
Okay, and how are you feeling now?
How I'm feeling now? I'm feeling really good, actually, and I feel like this whole experience has really shown me how, like, don't take stuff for granted, and really work on the fundamentals and everything to keep your body strong and healthy for your daily life and everything, and not just because for sports.
Yeah, well said. How would you describe your knee stability kind of on and off the court?
I feel like my knee stability now is significantly improved, not just because of the surgery, but also the whole therapy and stuff you have to go through, because all the exercises are strengthening a lot more than just your ACL to prevent that and everything.
And is there any other information, because there could be some viewers who are in the same situation that you're in, if you could just describe what your recovery has been like?
So recovery it was pretty smooth, honestly. It's a lot of work, so you have to be ready to put in the work to recover and everything. And I feel like you just need to keep working and stuff, and because your major goal is to be productive in life. And
Okay. And if there's anything that you could tell viewers or anyone who's contemplating the surgery, if you had a piece of advice, what would that be?
So obviously, I would say get the surgery and get a good surgeon like Dr. Metzler, and also make sure you do exercises beforehand, and make sure you continuously ice to keep the swelling down, and also get a really good therapist like Chris and the people at St. Elizabeth, and in my case, a great athletic trainer at my high school to further prepare me for getting back into play.
All right. Well, thank you, Molly, for sharing that. Again, viewers, if you have any questions, feel free to submit those, and we will answer them throughout the day. Before we sign off, would like to turn back to Dr. Metzler and just ask, is there anything else you could say on why is this surgery so important?
Well, we could talk about just, again, the stability. We talked about a little bit about preventing further injuries such as the meniscus. I think those things are the highlight of why we do the surgery. It's really not a question anymore. There's very few patients who we don't operate on because we want them to have a stable knee to be productive on. Again, I want to thank Molly for being here. She's been a model patient for us, and highlight the fact that the ACL surgeries, while they are routine, they're very complex. They're very tedious, and every step has to be very particular. And that's why we recommend a fellowship-trained sports medicine ACL expert or specialist to be doing this procedure. And it requires a team. It's one of those surgeries that you need a team for. Everyone's got to be on the same page. The trainer, if you're a high school athlete, it's got to be the trainer, or college athlete. The trainer's got to be on board. The athlete's got to be on board. The therapist has to be on board, the surgeon's got to be on board, and of all the things we do in orthopedics, it's one of those surgeries, and there's many like this, but it's really about a team approach. And if everyone's on the same page and everyone does their part, generally we're going to have some great outcomes for patients. And I think that's the one thing I'd highlight and take away from this session today. It's just how much of a team approach this is. If one piece of the puzzle isn't quite there, outcomes may be altered. They may not be as good as what we want to see. So I'm going to try to do everything I can to put a good ACL in you, and put a good ACL in Molly, right? And make sure she gets back to the court. But I need Chris's help, and I need Tom Burns' help. I need everyone's help to make sure this is happening. If she's doing her part and I'm doing my part, generally we're going to have a good outcome for our patients. And our re-tear rates are present. We know that it's not a perfect surgery. We reconstruct the anatomy to the best of our surgical capability. We do a good job of it with low re-tear rates, probably 5% or less, which is excellent. But we got to keep everyone on the same page.
Well said. Well, that's all the questions that we have right now. Do want to remind viewers, though, well, we have one that was just submitted. Is it common? Oh, this is a very good question. Is it common for someone to tear their ACL again?
So to answer that question, if you've had a previous ACL reconstruction and you look at re-tear rates, they are kind of a little bit all over rate-wise. Some studies will quote 5% re-tear. Some studies will say that female basketball and soccer athletes have up to a 25% incidence of re-tear rates. Certainly females are more common than males overall to tear their ACL. But yes, the re-tear rates do occur, and they are very variable in the science and data. And certainly within the first 2 years, there's a high incidence of tearing your other ACL, what we call the contralateral ACL, as you return to sports. Even though we're rehabbing everything together, it's actually higher than actually tearing the surgical ACL.
Okay. And here's a question for Molly. Molly, does having an ACL injury, does it change anything that you do in practice?
Yeah, I feel like, so since it hasn't been that long, it's only been about a year, they're still in the back of my mind. So before like practice and everything, I definitely stretch and do more exercises to like try and prevent and keep strengthening it. And I feel like it's still important to do some exercises and stuff to keep it strong and to prevent it as much as possible from not happening again.
So I think it's another thing that I'll interject here is that the scientific data is really important, and so it's been studied that the average person that's had an ACL surgery mentally takes 2 years to recover from that surgery, just the mental aspect. And while around 9 to 15 months, their knee looks good, it feels good, it looks like a normal knee, it acts like a normal knee. Psychologically, their brain takes 2 years to trust the knee on the average for the average human. It's just pretty impressive. So 2 years for someone to trust that knee, and you see that a lot in the NFL. Someone that they have their ACL reconstructed, and maybe it takes them 2 years to get their sacks back to where they were before, or trust their knee to get back to their 1,000-yard season. But it takes them about 2 seasons. If you watch professional sports, you're going to see that the first season back after an injury may not be their optimal season. It's usually the second season back where they kind of get back to close to where they were before.
That's interesting.
A lot of that is the psychology behind the injury.
All right. Well, before we close, again, viewers, if you have any more questions, we can answer those after the broadcast. At this time, I do want to thank our guests, Dr. Metzler and Chris, for joining us. And please stay tuned on StElizabeth.com for future Facebook Lives.